Well, hello, and welcome to Bingham Healthcare's Be Informed webinar series, which, as many of you know, is now streaming live on Facebook. I'm your host, Michael Brandis, with Bingham Healthcare. And I greatly appreciate everyone who has logged into Facebook and is joining us today for this live webinar. In case you aren't able to watch the webinar in its entirety, it is being recorded and it will be available on both of our Facebook pages, Bingham Memorial and Bingham Healthcare's Facebook pages, so you can watch it at a later time. In addition, it's also going to be on our YouTube channel at Bingham Memorial. So if you search for Bingham Memorial on YouTube, you'll see the webinar that's recorded. Just as a reminder, we had a webinar last week with Dr. Nicholas Pearson, who's an orthopedic surgeon for shoulder, elbow, hips, and knees. That webinar is now available on all of those channels as well. And at this point, just to make sure that you're engaging as many family and friends that you think would be interested in watching our webinars, please feel free to like this or share it with your friends and family when you can, just to be able to go from there. As many of you may know, Bingham takes great pride in the seminars that we've been holding throughout the years because we want to be able to give back to our community in ways that they can learn and be more informed about their health and about different issues that may be affecting them or their loved ones. And we, unfortunately, due to everything going on for the last few months, we've been unable to host our in-person seminars that covered a wide range of topics. And so that's why we found this creative solution to be able to continue to meet with our healthcare providers and have you be able to ask our providers questions to see what your next steps might be with your health or with the health of someone that you care about. So again, we really greatly appreciate you being here. The webinar is completely interactive. So if you have questions, we have a few questions that have already been sent to us by people who were aware that we were hosting this webinar today. I know that I'm getting text and Facebook updates with people asking questions while we're live. So if you have questions about the topic that we're going to be talking about today, you feel free to send your questions, and we'll try to get to as many of those as possible. Just to keep in mind, this is an hour-long program, so we'll do our best to be able to get to everyone's questions as best we can. So having said that, I'm really excited to introduce today Dr. Dan Robinson. Dr. Robinson, thank you very much for being with us today.
Thanks for the invite. I appreciate it.
You're welcome, and thank you for taking time out of your schedule. Dr. Robinson, his specialty is podiatry and orthopedics. He's a foot and ankle surgeon at Bingham Healthcare, and he specializes in the evaluation and treatment of a wide variety of foot and ankle conditions. Just to let you know in advance that Dr. Robinson actually sees patients in Idaho Falls, he sees patients in Blackfoot, and he also sees patients in Pocatello throughout the week. So if anyone is interested in scheduling an appointment with Dr. Robinson at any point, just know that those are your options. There is a phone number on the screen right now that you will start to see, and just please know that that phone number is for the Idaho Falls location. But if you were to call that, you would just want to let them know the specific city that you would like to schedule your appointment with Dr. Robinson in. Again, Dr. Robinson, thank you very much for being here. To start with, what I'd like to do is have you tell us a little bit about yourself, a little bit about your education, your background, and then we'll go a little bit deeper for the next maybe 10 minutes. And then from there, we'll start going in and answering some of the questions that our viewers are having. Is that okay?
Sure. I'd love to do that.
Okay.
So as you mentioned, Dr. Dan Robinson, I actually grew up in this area. I grew up in Rexburg. I went to high school at Sugar-Salem High School and graduated from there and stayed locally. Went to Ricks College when it was Ricks College and graduated from that university. It is at that point that I transferred to Idaho State University and graduated with my bachelor's in microbiology. And during that time frame, I had a love of medicine. I love to be around people. I worked as a CNA in a nursing home where I really found out a passion for serving and working with patients. And I thought, that's what I want to do in my life. I want to take the time. I want to be able to spend time with patients, because I love to see that interaction through a healthcare provider and with a patient. And just to see how big a difference you can make on somebody's life is one of the big turning points for me to decide, where do I want to go with my career. So at that point, when I was at Idaho State University and trying to finish up and deciding which part of medicine I wanted to go into, it was interesting that, now even days, I get a lot of questions. Why feet? Why did you want to work with feet? And the great question is always brought up. And it was amazing that at the time when I was looking at going into different areas of medicine, my wife actually ended up breaking her foot.
How did she do that?
She was very active in exercise, and back then, the kickboxing thing was a big thing.
Oh, okay.
And so she developed a stress fracture. And knowing myself, I just said, it's probably not broken. You're walking all over it. And this is before schooling, so just so you know, this is before I was trained to understand the function of the foot. And sure enough, her podiatrist actually diagnosed her with a stress fracture of a small bone in the foot called the sesamoid. And my wife just happened to talk to him one day and said, my husband's really interested in going into medicine. You mind if he comes in? He says, yeah, have him come in. So I went and I started shadowing this podiatrist up in Rexburg, and he's been kind of a mentor to me over the years. And he actually convinced me, in a way, to go down this route of medicine. And I haven't regretted it since. It's been a great career for me. And so once I made that decision, I applied and I got into Des Moines University out in Iowa, where I finished my doctorate in podiatric medicine. And in the meantime, I also had the opportunity to work on what's called a dual degree program, where we get a master's degree as well.
Okay.
And I decided, well, I'm going to do that because they're going to teach me all about medicine, but they're not going to teach me about how to run a business.
Okay.
And so I got my master's in health administration at the same time. And it was a great decision. I was the only one in my graduating class that did a dual degree during that time frame, which has been a great benefit for me, and it's been very helpful knowing the business side of medicine and not so much the treating side, because the medical degree got me that, but that taught me about business.
Okay.
And so that's kind of where we ended up. I did my residency in Denver, Colorado, absolutely loved it, and worked there for a couple of years. And then a recruiter found me that was referred by my mentor up in Rexburg, said, hey, he wants to get back here. So that's how I ended up back here. Recruiters brought me back.
Okay, that's fantastic.
So, yeah, it's been good.
So one of the things that I have a question for you is, and you already touched on this a little bit, but after your name, I know a lot of doctors have MD, DO, or there's a PhD as well. Could you elaborate on what DPMs? I know that your credentials are DPM and then MHA.
Correct.
What if someone were to see that on our website? What would that mean?
Yeah, and so with medical school at Des Moines University, we had classes actually with the Doctorate of Osteopathic Medicine, or the DO students. So our first 2 years consisted of the same classes, basic sciences, and then we branch off into our own specialty, which is the Doctor of Podiatric Medicine.
Okay.
That's what DPM stands for. And then the MHA is the Masters of Health Administration. So that was that dual degree program that I was able to participate in at Des Moines University.
Okay, thank you for talking about
You're welcome.
that. And then I know that you are double board certified. Could you talk about what your double board certifications are and what those mean?
Yes, and so in our profession, we have what's called a college. It's the College of Podiatric Medicine. So when it's dual degreed in my profession in podiatry, we can be certified in what's called foot surgery, but also certified in rear foot and ankle reconstruction. It takes specific residency programs and time in residency in order to qualify for those, and also specific numbers of surgical cases. And so some of the people in podiatry will get certified in foot surgery only and not able to get certified in rear foot and ankle reconstruction. And I was able to do both of those. Okay,
wow, that's really interesting, and probably a lot more intricate than people would really. I mean, because you're dealing with tiny bones as opposed to like a knee surgeon or
Right.
like it's really intricate work.
Yeah, so everything's small. So that's the challenge to it, is everything's small, and it's not like you're working on a great big big tibia or a femur. Everything's very small, like you said, and so it takes quite a bit of knowledge to know about the anatomy in order to be proficient at what we do as far as podiatric surgeons.
Okay, so As all of our viewers, as you are aware, we're talking about the foot and ankle, and I think that it's one of those body parts that we actually really, really take for granted until something happens or you're in pain, and then you just realize that just how much you rely on your feet on a daily basis, and the thing that I think about is. I actually don't know what I think of it. I've lost that thought, so I'll have to recover it. But I know that you see patients for heel pain, foot pain, bunions, hammer toes, and other foot deformities are just some of the conditions that you help your patients to improve. And I know that you also work with diabetic patients or type 2 diabetes patients to make sure that the health of their feet is really being looked after and taken care of. Can you talk about some of the specialties, some of the patients that you see, the age ranges of patients, maybe some of the more common foot problems that people might be experiencing, and then we can kind of go a little bit deeper.
You bet. So, for what I typically will see, I see a wide range of patients from all ages. I see pediatric patients anywhere from a month or two old on up to the geriatric patients that are, elderly in the 80s and 90s. And each one of those age categories is so different. That's what makes it a little bit of a challenge. So those are the patients that I typically will focus on is a wide range. When it comes into pediatric stuff, that's a whole new ballgame when it comes to treating the foot and ankle. And so some of those I may refer to somebody that's better at pediatric care, and there's great specialists out there specializing in nothing but pediatrics.
Okay.
And so that's probably one that is a little bit more of a challenge, and I see very few of. But in between that, anywhere on up, like I said, at the geriatric ages, I see all types of those people. And it ranges from, birth deformities to injuries, whether it's sports related or somebody had just fallen down because the weather's been bad and they've slipped on the ice. All kinds of things. Bunions and hammer toes are very common. A lot of heel pain, ankle deformities, a lot of ankle pain, and just people just hurt when they walk, and they need to know an answer. Well, why am I hurting? I've had no injury, and that's the fun of it. You get to figure that out with them and try to decide, okay, this is the problem, and this is how we would fix it.
Well, actually, something that you said actually reminded me of what I wanted to say is that. Excuse me, it's my understanding that even if someone is experiencing just pain in their feet or in their ankles, that can literally affect almost every other part of someone's body.
Right.
I imagine that they can have calf pain, or they can have hip pain, or they can even lower back pain can resonate from the feet. Do you see? Is that true?
Absolutely. So you think about your feet as being your foundation. That's the platform that you're walking on all day. And if that's not right, your whole mechanical aspect of your legs, your whole body is off trying to compensate for that. And so we see a lot of secondary problems that start to develop because of that. And if you can fix the foundation, if you will, or your feet and your ankles, and make sure they're stable and working as sufficient as possible, a lot of times the hip pain will go away, the knee pain will go away, and the lower back pain will go away.
Okay.
But it's fine-tuning everything. It's all, your body works in conjunction with itself, all the way from the head all the way down to the toes. And if one part of it's out of whack, then the rest of it doesn't function normally. So that's a big part of it, and that's part of our assessment is we see, okay, how is everything interacting? How is the foot and ankle interacting with the function of the knees and the hips? And all that has to take into consideration to get the best possible outcome for that patient.
Thank you for elaborating on that. And I think for all of our viewers, I think what's important to recognize is you can always talk to your primary care physician about ailments that you may be having, and even ask. Say, hey, I'm having this lower back pain, but could it be related to something going on with my feet? And just start having that conversation. And then there's the potential to be referred to Dr. Robinson to have him, again, like he just said, be able to run through a list and be able to kind of try to problem solve and figure out find the root of what's really going on. Okay, well, I think you've done a really great job about talking about what you specialize in and the patients that you see. So we have a number of questions. Why don't we jump into those? And then I think it might spark if there's anything that you want to elaborate on when we're answering these questions, feel free to, go
Sure.
from there. And I know you brought a foot. You brought a.
Yeah.
You
So I got
so
my
you
little.
can use that.
I've got my little foot model here. So this will help explain some of the processes, I guess, that we do and some of the surgical procedures that we do and how we diagnose that. But I just brought this by. If we need it, we'll use it. If not, then we'll just move forward.
Okay, cool. So the first question that we have is from someone who is 67 years old. They're active, not overweight. They're a non-smoker and non-diabetic. They say that their feet hurt between their third and fourth toes, and most of them are numb. They say that they wear wide, flat shoes, but still have pain that feels like burning and is very uncomfortable. Is there any proven procedure that can relieve the suffering? How would you respond to that?
Yeah, that's a great question, and I appreciate that being asked. In fact, this is something that we see on a regular basis, these same particular symptoms. Just going off the way that question was described in the question that they brought forward is, it sounds like what's called a Morton's neuroma. Obviously, without putting my hands on somebody, it's a little bit more of a challenge because that's what we do. We have to put our hands on somebody to really help with that physical examination. But based on that, it sounds like what's called a Morton's neuroma. Now, what exactly is a Morton's neuroma? So a Morton's neuroma is a disorder or a problem in the nerve that sits in between. I'll use my foot model to help explain this. So right in between these long bones, these bones are called the metatarsals. So there's a nerve that sits right in between there, and when it gets to the bases of the toes, it branches out to the toes. Now, in that particular spot, there's a good-sized nerve there. And what happens is that if we're wearing tight shoes over time or our foot structure changes, which it does do, it changes as we age, that you can add some pressure on that particular nerve or on that what's called the neuroma. So a neuroma is a pinched nerve or thickening of the nerve fibers that is very painful. And just as that question describes, it's a burning sensation. It's between two particular toes. And it's very common to see it between the third and fourth metatarsals that are affecting the third and fourth toe. And injection therapy works occasionally. That's something that we typically would start with is
Okay.
injection therapy, maybe some medications to help control some of the burning pain that they have. But in essence, if that fails, the next option would be surgical intervention. And we make a small incision on the top of the foot. We go in and we find that particular nerve, and we actually release it. We take that nerve out of there, and it's most of the time that we see that. In fact, a lot of the times we see that you can physically see the deformity of the nerve because it's so thick, and it's not supposed to be like that. But obviously, the diagnosis is truly made through pathology. We sent that to pathologists to identify under a microscope. But that majority of the time will alleviate that burning pain in those toes. Now, the downside to that is you have numbness between those two toes, partial numbness, which is still
Even
comfortable.
after?
Even after.
Okay.
Yeah, we'd rather have numbness than burning pain, and people are willing to change that because anytime you take out a nerve, you're going to be dealing with some numbness.
Yeah.
And that particular procedure is one of those. But it's great. People love that procedure. There's not a lot of downtime. I actually let them walk on their foot after a few weeks, and they do quite well with that procedure.
Okay.
So I would call that a Morton's neuroma, the way that question was describing the pathology and the symptoms that they're having.
Okay. So to the viewer that asked that question, thank you very much for submitting it, and I hope Dr. Robinson was able to answer your question. And again, if you would like to schedule an appointment or a consultation with Dr. Robinson, I know that he would be more than happy to see you. And again, the phone number is on the screen, and then he sees patients in Idaho Falls, Blackfoot, and Pocatello. And I think one of the important things to note from this as well is I think that when people have foot pain or experiencing something, they automatically procrastinate. They might tend to procrastinate wanting to see you because they're afraid that they're automatically just going to have to go into surgery. And I think it's important that you know that Dr. Robinson takes great care in making sure that he tries to come up with a number of different solutions before ever having to recommend, going into surgery.
Yeah, it's interesting that how many people will come in and their comment is after we start the treatment process is, why did I wait so long?
Yeah.
I could have been feeling much better a lot quicker. And I hear that a lot. And it's just the fear of coming in, I guess, and seeing a physician and thinking worst case scenario that, I'm going to have surgery. And there's a lot of times we can avoid that.
Okay.
So.
See, and I think that's something really important that Dr. Robinson mentioned. And I know that a large majority of our healthcare providers have adopted the same philosophy, where it's just That's why our providers are here. That's why they went to school, because they want to help people. They want to help people to be able to be pain free, and there shouldn't be any. You shouldn't allow any fear to get in the way of being able to contact one of our doctors to just have a conversation to say this is what's happening, and then they have the education and they have the background. Everyone specializes in something different around the world, and doctors. That's why they go to school, is because they want to help. So don't hesitate to reach out and schedule consultations if you are experiencing pain of any sort. And like Dr. Robinson said, people regret not coming in sooner, and so you can make that choice. So another question that we have here is from a viewer who says, while some days are good, I will occasionally experience debilitating pain in my ankle from where it was fractured about 20 years ago. Despite having an MRI showing significant inflammation in the soft tissues in the joint, the last ankle specialist I saw tried to tell me the pain was all psychological because the human body doesn't experience real pain for that long. The radiologist says the pain is real. Who should I trust? How do you address that?
That's a great question.
Passionate.
And that can be frustrating too when you're physically having pain and you can't seem to get the answer for that. And that's the wonderful thing about medicine is it's practicing medicine. It's going through the process of trying to get a couple of diagnoses and then trying to weed through that and truly figure out what the problem is. And that's the challenge that we face in medicine is what is it? But it is frustrating on a patient side when you can't get that answer that you want. Now, just based off that little bit of information, the first thing that comes to my mind would be post-traumatic early signs of osteoarthritis of the ankle joint. Just because you don't see potentially joint space narrowing or the cartilage seems to be wearing down quite significant doesn't mean that you're not developing post-traumatic arthritis. You could have developed that, and that would be the sign of the inflammation of the ankle joint. It could be stiffness in the ankle joint. So without doing a complete physical examination based on this question, my first initial thoughts were post-traumatic osteoarthritis that is developing without the destruction of the cartilage quite yet. Okay. The other thing I'd like to really do is to check that MRI and see, okay, what about the ligament structures? What about the tendon structures around that particular area? Do we have a nerve problem that's going on? There's nerve issues and disorders that can occur from trauma that needs to be ruled out as well. So even though an MRI is helpful, it's not truly a full diagnosis type of modality or treatment. That gives you a kind of a roadmap, if you will, to kind of weed out other problems. And so I don't base everything on a complete MRI. I go with the clinical examination as well, what the patients told me, and also the history that's involved with that. But just initially, that sounds like early signs of post-traumatic arthritis, just based on the way that question has been asked.
Okay, thank you, Dr. Robinson. Thank you to our viewer for asking that question. I hope that provided a little bit more insight for you. So we have a couple of questions that are related to hammer toe. So I'm actually going to combine those.
Okay.
And so the first part of the question is, my husband's toes are constantly curled up like he's worn shoes that were too small for years, even though he hasn't. And then, is this a problem or can it be fixed? And then you had mentioned it sounds like hammer toe to you. So then what does hammer toe look like in your experience, and how would you fix it?
Yeah. So I'm going to refer to my model for this too. This will be a good one to kind of describe as far as what a hammer toe looks like. So if we're looking at the model here, we have obviously our toes. The smaller toes, typically I'll have 3 joints. And what happens with those is that as the toe bends, it starts to curl up like this. And we get that big bone prominence on the top of our toe, and it rubs on the inside of the shoe. And it becomes to the point sometimes where it's so stiff you can't even straighten it back out. So our treatment for that is, first of all, what causes that hammer toe? That could be a muscle imbalance. That could be a neurological disorder that's causing that. It could be trauma that has caused that. There's multiple reasons. Footwear, as a child or during those development years when our foot structure is changing so much, many of us, if we can remember, had hand-me-downs. A lot of the shoes were passed down from brother to brother and whatnot, or sister to sister. And that can play part of it, depending on how bad and how tight those shoes fit as a child. But just normal wear and tear on your feet over time can develop these. So there are treatments for that. Some people don't want surgery for hammer toes, and we can get them into what's called an extra depth shoe. They're special shoes that have extra depth to them to allow the toes to sit in there, and so they're not rubbing on the inside or the under portion of the shoe. From a surgical standpoint, however, we have to typically will go in and we'll resect or take out the joint itself and fuse those two bones together. So we go from here to a straight toe like this. There are different types of methods of doing that. Sometimes you put a pin through there to hold it in position while those two bones fuse together. Sometimes it's just releasing a tendon that's really tight. We don't have to do any bone work. And that's what's involved with that clinical examination is trying to figure out, okay, is it just a tight joint or is it a tendon issue? What other underlying issues may be doing that? But there are ways to treat it. And the most common is to take out the joint and try to fuse those two joints together with either a pin or some type of a screw to hold them together while they fuse.
Okay, thank you, Dr. Robinson.
betcha.
Again, to our viewer, I hope that helped to answer your question, or to the several viewers who had written in about hammer toe. I hope that that shed some light on what you might be experiencing. You had mentioned, and I thought this might be a little bit of a segue. You talked about footwear. Can you talk about? I know that everyone is unique.
Mm-hmm.
Everyone participates in different activities, different sports, from walking to running to hiking to skiing. What can you talk about when you talk about foot health and what are some of the basic guidelines that people can follow with wearing proper footwear? And even when you talked about little kids, I forgot about that. I have a 2.5-year-old niece.
Mm-hmm.
What should parents be looking out for when they're first having their children wear shoes?
Yeah, so I get this question a lot from parents that come in and they've just noticed that their son or daughter is walking, their feet are really flat, and they wondered, well, why is my son or daughter tripping over themselves as they're walking around? And they always ask me, what is a good shoe? And I always tell them the same thing. It says there's multiple good shoes out there. The question is, what is the best shoe for your son or daughter, or for you? And that's the tough question. And so, not to say there's a particular brand out there that's better than the other, because it all depends on the patient's foot type. But what I do look for in a shoe is a rigid sole, so it's really stiff, so it doesn't have a lot of bend in it. A good support through the back side of the heel that's nice and firm, that doesn't have a lot of play in it. And that'll give, and it also something that has somewhat of an arch support through it.
Okay.
And that typically is a good shoe. And that's what you want to look for in a shoe. And you don't want something that you can grab and you can kind of roll it up into a ball that's really flexible and just not giving you any support. That's really not what you need. Those kind of things are okay, but on a daily basis, you want something that's good and supportive. And so those aspects of the shoe are really what I push, not only younger kids or teenagers, but adults as well.
Okay, and this might be a little bit controversial for our women viewers out there, but high heels, what do you see with the long-term?
Good old high heels. Love high heels. They keep me in business.
Oh, gosh.
So high heels are great. If you think about the mechanical aspect of the foot inside of a heel, I mean, there's nothing that looks comfortable with that. They're great. They're good-looking shoes, and I never tell a lady that she can't wear her high heels. That's the worst thing I can do to tell them.
My sisters would be frustrated.
They'd be very frustrated because they love their shoes. And I said, in moderation is great. It just don't make it your daily shoe.
Okay.
You know, if you want to go out for dinner, or you're going out someplace nice, or you just want to wear one day, that's fine. You do it. There's nothing wrong with that. It's the repetitive, I wear stilettos every day. That's when we start to see ankle problems. We start to see the curling of the toes that we talked about with hammer toes. That's very common to start to see. But it also puts a lot of stress on the joints of the foot. It's called the metatarsal phalangeal joints. And that's these particular joints right across through here. If you think about your foot going into a stiletto, think about that pressure right through the ball of your foot as you come down on that. That's not going to feel very good over time. And so you get a lot of stress through this particular part of your foot, and that's basically what makes those so uncomfortable. How many women do you know that put on those particular types of shoes and they get home and says, I can't wait to get these shoes off. They look good, and they like to wear them, but they're always ready to get them off. And so those are the reasons why. It's making your foot function in a way that it's not really intended to do.
Okay.
But never tell them, don't ever wear those again. That's not a good thing to
Just
do.
every now and then.
Yeah, every now and
then.
then it's okay, in moderation.
Yeah,
You bet.
and I even bet that long term wearing of that too would hurt, would have lower back issues and shoulder.
Potentially,
I mean, potentially.
yeah, potentially. How it depends on how high those things
Yeah,
are.
yeah.
Yeah.
Okay, and then not to mention twisting your ankle and those
And that happens quite frequently. Women will fall with these on and have really bad ankle sprains or actually fracturing their ankle. That happens multiple times. I've seen that plenty of times.
Okay, so be careful. Thank you.
Yeah, just be careful.
Just be careful. What about bunions? What is a bunion and what creates a bunion? What should people be looking out for that?
Yeah, once again, we'll refer back to our model for that because it'll help explain that. So a bunion is a deformity of the first metatarsal. So this bone right here. So what happens is that starts to drift over like this, and then the big toe starts to drift the other way like this. And we get this big bump that sits on the side here. And that can happen for multiple reasons. Once again, it can be genetics, it could be trauma, it's typically could be muscle imbalance. Those kind of things can make a big difference in developing of the bunion. And everybody says, well, is it going to get worse with time? Most of the time, these will get worse. They're a progressive sliding of the metatarsal, that bone out of position, causing that big bump on the side of the foot. It can be very painful because there's a nerve that runs right along the side of that particular bone.
Okay.
And if it gets bad enough, then it's a more aggressive procedure in order to fix that problem. I always tell people, or they ask me, when should I have this fixed? And I usually tell them, when it hurts and you can't do the things that you enjoy doing, that's probably the best time to have it done. When you're not having any pain or discomfort, we just watch and monitor unless they say, I want it fixed now because it'll probably be easier to heal from and be able to get back on my feet faster now than 10, 15 years from now.
Okay.
Okay. And so it does require sometimes just shaving a little bit of the bump off. Most of the time it requires actually cutting through the bone, or what's called an osteotomy, and moving that bone back into position. And usually you have to put a couple of screws in for that because you're kind of creating a fracture to fix the deformity.
Okay.
And that's the healing part, which takes about 4 to 6 weeks before I typically will let my patients walk on them.
Okay, so that was what I was going to ask you. So on average, it would be 4 to 6 weeks if someone were to have that surgery.
Yeah.
Okay.
So-
What's the follow up with that? How do people follow up with you, and
Yeah.
what do you recommend?
Yeah, and so just to backtrack just a little bit, some of the interesting things, some of the new procedures that are coming out, they're actually trying to get people walking faster with some of the new hardware and the plates that we're using to correct these deformities. A lot of times they can get on their feet faster and quicker. But the post-op course and recovery for this, like I said, my patients typically are 4 to 6 weeks before I let them walk on it. And then we start some range of motion, starting to get them walking in the regular shoes at about 6 to 8 weeks, somewhere around that time frame, depending on how they're doing and how the x-rays show that they're healing. And I usually don't do physical therapy for these. Just getting back and walking normally is usually the best therapy for it.
Okay.
Occasionally the joint will be a little stiff and we'll have to have a therapist work on that. But otherwise, from start to finish, I see you day one and then I discharge you anywhere from 2 to 3 months, depending on how fast you're healing up.
Okay, that's great. Okay, so continuing on. There's some more questions that have been coming in from our viewers, and just to let you know, we still have time. We have a few more questions to get to, but if you're out there watching, liking and sharing this video, please feel free to submit your questions, and we'll be able to try and have Dr. Robinson answer those questions for you. So we have a viewer that has asked, does having clubbed toes mean you could have heart problems?
Yeah, so that's a tough question to answer. Just because your toes are clubbing or more what's called a hammer toe, I wouldn't say that's directly related to any type of particular heart problem.
Okay.
There may be studies that I'm not aware of that may mention that in their studies, but most of that is a mechanical problem as far as the clubbing, or a neurological issue that can cause the clubbing too. Those are probably the more common reasons for the clubbing, or I should say the hammer toe contractures that we see.
Okay.
So, no information right off the top of my head that would relate heart problems to clubbing of the toes, unless there's a vascular issue or something that's compromising blood flow to those particular areas of the muscles.
Okay. So, and I'm going to say this word 2 different ways just to make sure I can clarify. So another question that a viewer has sent in is, I have what seems to be I want to say lymphoma, but lipoma?
A lipoma.
Lipoma. I have to be is lipoma on the outside of each ankle. They are quite low and affect the shoes I wear. She doesn't particularly care for them. At her age of 79, she would like to get them taken care of. So first of all, could you let us know what lymphoma is and
Yes.
how you could help her?
So the more common term that you hear a lot of people say, I've got cankles. That's
Oh,
not a
okay.
medical terminology. We don't use cankles.
Okay.
All right. So a lipoma is a deposit of fatty tissue or adipose tissue around the ankle joint. It's usually at the front outside portion of the ankle, and it makes it look like your ankles are much, much larger. But it's just a fatty deposit, and you can take it out all in one piece. Surgical dissect that out of there, and it releases or removes that fatty deposit around the ankle joint. And it's not inside the ankle joint, it's just right underneath the surface of the skin, and so it just sits right there, and you can actually remove those, and they do quite well with that. That doesn't mean you wouldn't be able to reform more fatty tissue there. There's always that possibility.
Okay.
But when it starts to interfere with the type of shoes that you wear, or it's rubbing on your shoes, then a lot of times it's beneficial to remove that fatty tumor, if you will. It's a benign growth. It's not a cancerous growth for the most part. So that's why it's called a lipoma, but we can remove those and actually give you more room for your shoes so you're not irritating the skin around the ankle joint quite so much.
Okay. And again, I'm sure it would vary on the situation and the extent of the lipoma. What kind of recovery time would someone be looking at after you help them remove that fatty tissue?
Yeah, that's the nice thing about a lipoma is I let you walk out of the hospital that day or a surgery center, wherever this procedure is done at. The incision is healed in 10 to 14 days. That's typically when we take the stitches out. But there's no restrictions really as far as weight bearing on this. I let you walk, so there's not a lot of downtime other than you just had surgery. You're not going to want to run out and run a marathon or go swimming in the swimming pool until everything's healed up. But you're able to be mobile. You can still go back to work and do those things that you need to get done during the day and just let the incision heal, and then you're actually pretty good to go after that.
Okay.
So,
Thank you.
yeah.
So here we have another question from a viewer. This is for their mother-in-law. The viewer writes in that her mother-in-law works 12-hour shifts in a factory making kidney dialysis equipment. She's on her feet all day long on concrete floor, which I imagine a lot of people work under those conditions.
That's a tough environment.
For about 6 months, she has had on and off again pain, but in the last 2 months, it has been very severe. She went to her primary care provider, and they thought it was plantar fasciitis. They gave her an injection and at-home exercises. There have been a number of things that she's done, including to having had other injections, which she unfortunately had a bad reaction to. And she's stated that she was told that the pain is not from a bone spur, but didn't offer anything else that it could be or what she should do. So she's going to get an MRI this week, but she's in so much pain and having to miss work because of the pain, and she can hardly stand to bear weight on her feet. The pain is mostly in her left ankle joint on the outside. I know she's asked a number of different. Could this be Achilles tendon issues? Maybe something surgical, and also is this something that she could come in to see you for? So she's addressed plantar fasciitis. She's addressed Achilles tension issues, and she's also mentioned bone spurs.
Yeah.
How would you respond to this kind of question?
So a lot of information in there to weed through on that. And so let's talk a little bit about the concrete floors. There's no forgiving on concrete. Everything that's being absorbed as far as shock and standing is going right up through your feet into your ankles and through the rest of your body. Concrete is so unforgiving, and it really plays a role on your foot structure and your ankle structure as well. So plantar fasciitis, that's probably one of the more common things, which is inflammation of the big ligament that sits on the bottom of our foot that attaches to the heel. That's usually the one that's most stressed on concrete. I also worry about potential stress fractures. I worry about stress fracture in the heel bone itself on concrete floor, especially if it's excruciatingly painful to walk on. You don't have to have trauma or jump from anything high to develop a stress fracture. It could just be the stress of walking and standing on concrete all day. That can do it. I start to worry too about nerve problems being damaged that way. Is she developing a neuroma, like we talked about earlier, or even some tendonitis? I worry about the ankle problem because there could be malalignment of the ankle joint, or the heel may be sitting in a wrong position, causing stress through the ankle joint, and that would need to be addressed. So there's a lot of areas with this particular question that need to be addressed, and I think an MRI is probably appropriately this time to give you a better idea. Okay, that'll tell you, okay, well, where's the inflammation at? Do we truly have a stress fracture developing? What does the cartilage look like in the joint? All those things play a role into what could potentially be causing her foot pain and especially her ankle pain. So that's one that hands-on in an MRI would be really beneficial to really answer that question appropriately. So that's a tough one to just do over a webinar or something like that. That needs to be looked at in further detail.
Okay, thank you, Dr. Robinson, and thank you to our viewer for writing in for her mother-in-law. This is definitely something that Dr. Robinson could see you for. Again, he sees patients in Idaho Falls, Blackfoot, and Pocatello. There is a number on the screen, so you're able to call his Dr. Robinson's Idaho Falls office and schedule that appointment. The other thing is, for those of you who are unaware, if there's any additional information you'd like to learn about Dr. Robinson and some of his advice and content that's been written for him about the feet and ankles, you can visit our website at www.binghammemorial.org. www.binghammemorial.org is a really great resource. There's tons of content on there. There's tons of information about all of our providers and all of their specialties. So we highly recommend that you check out our website. And I was going to mention with the concrete, I feel bad for people that have to work, on concrete in factories for long. I even notice it. My parents, their home is built they've never done this before, but their house is built on a concrete foundation. They have hardwood floors, and we're not allowed to wear shoes inside the house. So we're always wearing socks or slippers. And I even noticed just after several hours, just the back of my calves are totally hurting just from walking around on that. So I can't imagine what people, who are working. Is there any footwear recommendations that you have for people who have to work on concrete or?
That's the other good point to bring up is what's the appropriate footwear to wear on an environmental surface like that, like concrete. And I mean, obviously you look for something that's got a pretty good, thick, supportive sole on the bottom of it. It's going to absorb a lot of this shock, and there's specific shoes out there that can do that. A problem is that a lot of people that are working on concrete in a factory setting or whatnot have specific shoes that they have to wear to protect themselves.
Oh, okay.
Steel-toed boots and shoes are a big part of it. The anti-slipping type of soles on the shoes are a requirement in a lot of these facilities too. So it's really kind of a challenge to find an appropriate shoe, I should say, that they can wear on concrete. And my suggestion is get something that's got a thick sole on it and something that's very comfortable, that you can at least be comfortable through as much part of the day as you can, even though concrete, it's hard to be comfortable all day on those type of surfaces.
Okay. So another question that's just come in from one of our viewers is, and you actually have touched a little bit on this earlier, but I don't know if there's anything else that you might want to add, is I have a bunion starting and have a question if there is any form of preventative or correction I can do in this early stage to help it.
Yeah, so when a bunion starts to develop, as we mentioned before, is it a muscle imbalance? Can that be addressed? Is it tightening of the ligament structures around the joint, and can that be addressed and stretched out during this process? And it's possible, but more than likely, it's the bone has shifted enough that it may not develop any worse than what it is. That's the thing, is a lot of times I say, well, let's watch and see what happens with it. If you're not really having symptoms with it, we shouldn't really have to do anything. Maybe a little bit wider shoe that has more room in the toe box, meaning there's more space in the toes where they're not being squished together. That might be a benefit too, to help prevent further progression or rapid progression of this particular issue.
Okay. And another question that has come in from one of our viewers is, and this is a little general, but maybe we can kind of try to think about it a little bit, is okay. I have seen some devices that go between your toes for relief, I imagine for pain relief. Do these work at all? and what those might be.
Yeah, that's a great question too. When it comes to the toe spacing, there are multiple pads and shoe inserts, I guess, that you could put in between the toes. And there are times when I actually recommend that. Sometimes people just aren't a surgical candidate. They have too many health issues that won't allow them to go to have a surgery for deformities in the toes. And there's so many different types of toe spacers or toe pads out there. I'm a big fan of like the silicone type of gel spacing type of pads. Something that's going to be more of a soft. It's not going to allow a lot of sweating between the toes, and that seems to be good. But there's so many out there, and I usually just tell them, get online, order 3 or 4 different types of toe spacers, and whatever one feels the most comfortable, that's the one you should probably go with.
Okay.
But they can be a benefit, especially if you can't have surgery or shouldn't be having surgery.
Okay, thank you
yeah.
for answering that, and thank you to our viewer for asking that question. So I just wanted to let our viewers know again. Thank you for joining us. We are getting ready to wind down. We're nearing the 1 hour mark. So if you do have any more questions, please feel free to start submitting those so we can get those in and ask Dr. Robinson those questions for you. I was going to ask you, in general, what do you recommend to patients or people in general about general foot care? Do you recommend foot massages, reflexology, acupuncture? What kind of cleaning should people be doing? What kind of toenail management?
Okay.
What do you recommend? What are some of the basics that people can be doing on a daily basis?
Yeah, so basic foot hygiene, that's kind of where we're trying to summarize that. Obviously, proper hygiene of your feet is just as important as proper hygiene of everywhere else on your body. And I usually counsel patients and discuss what that means. And that means, take some soap and water, wash your feet every day. Just because you shower or get in the tub doesn't mean you're actually scrubbing your feet. They're just sitting there. Don't forget to reach down and scrub your feet. Cleaning between the toes. And there's a reason why that. It decreases the bacteria, decreases the amount of surface fungus that might be on your skin, and decreases the potential for developing infections like athlete's foot or fungus in the toenails if you do good, proper hygiene. Sometimes no matter how well you do it, sometimes you're still going to get those things, but that really helps. Clean socks. If you wear a lot of sandals, make sure you're spraying down your sandals and keep them clean with a Lysol or something like that to disinfect them. That helps too. And nail care is always a question. How short do I cut my toenails? Just don't cut them too short. And sometimes it takes a trip in to see me, and that's sometimes all I do is visit with somebody and say, hey, this is the proper way of taking care of your feet. This is how you take care of your toenails, because a lot of people do it wrong, and they end up getting ingrown toenails or other issues. But just basic care, just good old soap and water on a daily basis, and making sure that you're not going to some place where if you're going to get a pedicure that you're going to go someplace where it's filthy, where they don't sterilize their instruments. Make sure they sterilize their instruments and have the proper way of doing that, and that'll prevent getting infections from going to those type of facilities, and hopefully most places are doing that. But those are the things I'd caution people on.
Okay.
Just basic, simple soap and water, making sure the facilities you go to have your toenails done or pedicures done, that they're clean and they sterilize not only their instruments that they use, but also the basins that they're soaking your feet in,
Okay.
in between visits.
Okay. So just, again, what I'm hearing from Dr. Robinson is if you do go and get regular pedicures, just make sure, you're the customer, so you have the right to ask the questions about how often they are sterilizing, because it's your health and you want to make sure that you're properly taking care of your feet. So
The one thing to expand on that
Okay.
too is when we're talking about nail care, earlier we mentioned a little bit about diabetes, and everybody says, well, I'm a diabetic, do I need to have my toenails addressed by a podiatrist, or do I go get a pedicure? And I caution with diabetics, it can be very difficult because they're more prone to infections, their immune system isn't that good, and a lot of times they're cut improperly and they end up getting infections. And then with a diabetic, they can't sometimes feel pain, and so they may have an infection going on that they don't realize is going on until it's too late, and they get ingrown toenails. Or sometimes, worst case scenario, they end up getting a bad infection where we actually end up taking a toe off or amputating a toe. And that's all about that proper hygiene and your regular diabetic foot examinations that you need to come in and see your podiatrist every 6 months, sometimes once a year, and depending on how bad the feet are, every 2 or 3 months to have the nails trimmed properly to avoid those infections. So diabetics, I really like to see those in a professional's visit because they can teach them how to do things. And we not only look for those type of issues, but how about the circulation in the feet? That's a big thing for diabetics. How about the sensation in the feet? That's a huge thing too for diabetics that we have to check on a regular basis. And so I recommend that more so for diabetics to have their nails done that way than actually going into a salon or something and have a pedicure.
Okay. And so our diabetes specialist is Dr. Angelo Capriccione. And do you work closely with him and his patients? So that,
Yes.
So even though if they are diabetic patients are seeing Dr. Capriccione, they would then recommend that they see you every 6 months.
Correct. And we work really closely. So when it comes to managing diabetes, even though you think it's a diabetic foot, you just need one of us. It's a team approach when we treat individuals with diabetes because there's so many things that can go wrong. And so just to have one person on board or two people on board managing a diabetic patient, in my opinion, is not sufficient enough unless they're well controlled, and that's very far and few between. But it should be a team approach taking care of that.
Okay. And so if there are viewers out there or people watching this that, do have diabetes, please, make sure that if you'd like to have a consultation with if you're not seeing a podiatrist, please make sure to schedule an appointment and, Dr. Robinson can get you in and help to give you a plan or a path to be able to make sure you're adhering to proper foot care.
Right.
The other thing I wanted to ask, because I know we have a lot of runners out there, are there any general things that you can recommend for people to run safely? We want them to get the exercise, but what should they be doing to be safe while they're running?
Yeah, that's...
Because that can lead to a lot of long-term.
It is, and it's commonly brought up too. So some of the major things that you can see with those that just like to run, and that's all they like to do, is we'll see tendonitis issues, we'll see plantar fasciitis problems, we'll see stress fractures start to develop. So a good supportive shoe like we reviewed earlier today is great. Runners that are running a lot of miles should probably switch their shoes out every 6 months, if not every year. They just get broke down so quickly with the number of miles. It's a high impact activity. You're doing a lot of pounding. And the surfaces makes a big difference too. If you're running on concrete, obviously we've learned that that's not the best thing to run on. Asphalt, grass, and dirt obviously are probably one of the better ones to run on. But switching your shoes out frequently. But those are the main things we'll see. And also, the important thing is cross-train. Don't just be a runner. Do other things too to take and let your body rest. You can swim, you can bike, and still maintain your cardio. But if you're going out and just doing nothing but long distance running, you're eventually going to have fatigue and have those secondary problems develop that we just talked about.
Okay. And I imagine the same thing would be at the gym. Like if they're working on different equipment, like a treadmill or an elliptical, they should be cautious as well with the footwear that they're... Okay.
For sure. Just something that's good and supportive and comfortable.
Okay. So we're getting towards the end. I did want to mention really quick that I know that you do see patients via telehealth.
Yeah.
Maybe not necessarily for an initial consultation because orthopedics you really more are hands-on, but for follow-up. How have telehealth visits been working for you the last few months?
Yeah, telehealth has been a blessing in disguise for not only for the physicians during this time with the COVID-19 pandemic, but also it's given us the opportunity for patients to stay home and be safe. And insurance companies have actually allowed and relaxed some of the restrictions on using telehealth for us. As you mentioned, obviously it's difficult for us that are in orthopedics and do what we do, where a lot of it's a hands-on type thing, but we can set up telehealth where we visit with one another over the computer, where we see each other, either that or your mobile device, and we discuss your health problems. Telehealth has been great for reviewing MRI results, doing some follow-ups on medications, how you doing pain-wise. Those type of things have been really helpful, and saving the patient coming into the facility, especially with everything going on in our communities, and it's been really beneficial. And I wish it would stay around for a long time. It all depends on what insurance allows us to do, but for right now, it's been a real benefit for us to cut down on those visits with people potentially being exposed to others that have it, so they can do all this at home. But for orthopedics, like you mentioned, there's things where we have to put our hands on to try to diagnose and help and treat. but it's been very beneficial.
Okay. And just to let you know, Dr. Robinson's continuing to see patients in office. He has been for the last several months at Bingham Healthcare and all of our facilities, Bingham Memorial Hospital and all of our clinics throughout Eastern Idaho. We have taken COVID-19 extremely seriously. We have created customized waiting rooms, so there's social distancing. All the patients that come into the hospital or into the clinics receive face masks. All of our everything's being constantly disinfected. So it's still really safe to be able to continue seeing patients in person, but then telehealth is also an option. Is there anything else that I should add on to that
I think
to
that's-
reassure people?
Yeah, and we're taking every precaution possible. We're masking people. The physicians are being masked as well. Just trying to make sure that we're doing our part. And not only are we doing our part, but obviously we ask the patients to do their part and wear a mask when they come in and see us, at least for right now. But yeah, there's been teams made up to try to protect all of us the best that we can, and usually making weekly adaptations as needed as we go along through this process.
Okay, thank you. So Dr. Robinson, we're nearing the end. I know that we've had a really great conversation today. We've covered a lot of topics, and our viewers, thank you very much for your engagement and for all the questions that you've been asking. They've been incredible. Is there anything that has popped into your mind that you wanted to talk about, or that you thought you might want to talk about, but you haven't had the chance yet, or have we covered
Yeah, I think we've covered quite a bit today in this time frame that we had. I think my biggest advice would be if you have questions or if you have doubt, just come see me. See somebody that's specialized in that particular area that you need to see. And because I mentioned earlier, it's amazing how a lot of people will say, I wish I would have come in earlier and got those answers that I needed and got the relief that I needed. So don't wait, don't hesitate. Come and see us.
Okay, thank you very much, Dr. Robinson. So I just wanted to remind you that Dr. Robinson sees patients in Idaho Falls. It's at our Comprehensive Care Clinic building. It's near the corner of Sunnyside and Hitt Road. And the phone number for that clinic is 208-524-9400, which is actually on the screen. He also sees patients in Blackfoot at the Bingham Memorial's Medical Office building. If you're interested in scheduling an appointment in Blackfoot, you can call 208-782-2490. Again, 782-2490 for appointments with Dr. Robinson in Blackfoot. And then he also sees patients at our Physicians and Surgeons Clinic of Pocatello, which is on Hospital Way. And to see Dr. Robinson in Pocatello, you would call 208-239-8010. Again, 239-8010. And for additional information, you can visit our website, binghammemorial.org, for all those phone numbers and for all those office locations to be able to schedule an appointment. Again, Dr. Robinson, thank you so much for being with us today.
It's been great. Thank you. Appreciate it.
You're welcome. And again, thank you to all of our viewers. Please keep an eye on our Facebook pages, Bingham Memorial's Facebook page or Bingham Healthcare's Facebook page. We're going to be hosting these webinars, these Bingham Healthcare Be Informed webinars as close to a weekly basis as possible. So stay tuned for our next provider, and we'll see you next time. Thank you very much for joining us.